This is The Rounds Table.
Welcome back, everyone. This is John Fralick, one of your hosts. Today, we're doing a solo episode related to hypertension. The paper is Antihypertensive Medication Timing in Cardiovascular Events and Death, the BedMed Randomized Trial. This was published in JAMA May 2025 by Garrison et al. So the research question here was, does bedtime administration of antihypertensive medications compared with conventional morning use reduce a composite of death or major cardiovascular events? So why is this important? Well, we know that blood pressure varies daytime versus nighttime, and sleep time blood pressure is thought to be a better predictor of adverse cardiovascular events. And prior studies have looked into whether administering blood pressure medications in the evening may reduce cardiovascular risk, but the results have been inconsistent. There was the MAPEC trial and the HYGEA trial, both by the same group of researchers, which reported a 61% and 45% reduction in major adverse cardiovascular events, respectively. But concerns have been raised around the study methodology, and in particular for HYGEA, it included whether patients were truly randomized, as well a large effect size that may have been kind of too good to be true. There was a third trial, the TIME trial, by a different group of researchers, and they found no benefit in bedtime medication administration, in part due to poor adherence and a lower risk patient population. And so here, Canadian researchers performed the BedMed trial, where Canadian adults with hypertension in primary care were randomized to bedtime versus morning administration of all once-daily antihypertensive medications. So for the design, this was a prospective randomized open-label blinded endpoint assessment clinical trial. Patients were recruited through 436 primary care clinicians in 5 Canadian provinces. For the patient population, they were adults aged 18 and older with a diagnosis of hypertension taking one or more medications for blood pressure lowering. All types of blood pressure lowering medications were included. For the key exclusion criteria, if patients had jobs that included sleep-disrupting shift work, they were excluded, as well as those with glaucoma and those living in continuing care facilities. For the intervention, patients were randomized 1-to-1 to once-daily antihypertensive medications at bedtime versus morning. If patients were intolerant of bedtime use, then dinner time use was encouraged, and if patients were intolerant of morning dosing, then lunchtime use was requested. Follow-up was done over a median of 4.6 years. For the primary outcome, this was time to occurrence of a composite of death and major cardiovascular events defined as first occurrence of either all-cause death or a hospitalization ED visit for acute coronary syndrome, stroke, or heart failure. There are also a bunch of secondary outcomes. This was an intention to treat analysis. So who was included in the trial? Well, about 5,000 patients were screened and ultimately 3,357 were randomized. 56% of patients were female, the median age was 67, the majority of patients were white, and 71% of patients came from Alberta. 18% of patients had diabetes, 11% had coronary artery disease, and 7% had chronic kidney disease. About half of patients were taking one medication for blood pressure control. Regarding the types of medications, 36% were on an ACE inhibitor, 30% on an ARB, 29% on a calcium channel blocker, 27% on a diuretic, 18% on a combo pill, 17% on a beta blocker, and 1% on something else. So what did they find? Well, as a reminder, the primary outcome here was death or major cardiovascular events, and they found that there was no significant difference between the two groups. Over a median of 4.6 years, the primary outcome event rate was 2.3 per 100 person years in the bedtime group and 2.4 per 100 person years in the morning group. This was a hazard ratio of 0.96 that was not statistically significant, with confidence intervals ranging from 0.77 to 1.19. Regarding adherence, at 6 months, 83% of patients in the bedtime group and 95% of patients in the morning group were self-reporting to have taken the medication as allocated. There were no differences in the key safety outcomes, and this included things like syncope, falls, and fracture risk. What are the key limitations here? Well, I think overall this was just a nicely done, pragmatic, randomized controlled trial. Of course, one consideration is that the measure for medication adherence, i.e. were patients actually taking the meds when they were supposed to, was self-reported. But I don't think there was any easy way to get around this, short of having a member of the study team show up at people's houses to watch them take their meds either in the morning or at nighttime. Clearly, that's neither feasible nor practical. So what's the takeaway message? Well, this study shows that taking blood pressure medications at night is not associated with improved cardiovascular outcomes. Is this practice changing? I think it's certainly practice affirming. I think we can ask our patients, what worked best for you? When do you want to take your medications? Is it easier for you to take them in the morning, easier for you to take them at night? Because I think for the average patient, it's probably more important that they take their medications consistently as opposed to a specific time of day. Also, big kudos to the researchers. We don't often cover a lot of trials set in a primary care landscape. This was a really important clinical trial. Good work. Well, that just about wraps up today's episode. But before we go, the good stuff, I guess by the time this episode airs, it's probably mid-August, which means trainees will have a full month under their belts. It's still pretty daunting to be a new R1 or a new R2. If you're looking for some good, quick resources, of course, I am biased, but I think medicinepods.com has some great resources, including infographics on just about everything. I guess for other stuff, ECGs, I'm a big fan of Life in the Fast Lane. That resource is pretty phenomenal. And with that said, good luck to all the new trainees out there. You just got to keep on pushing forward one day at a time. All right, thanks a lot for listening. Talk to you guys later. The Rounds Table is hosted online at medicinepods.com, your one-stop source for comprehensive internal medicine education and evidence-based medicine resources. We can also be found on all of your favorite streaming services. You can also follow us on Instagram, LinkedIn, and X.